the most common questions I get from doctors, dentists all over the country is how can I grow my revenue? And there's a million solutions to that problem. Today we want to focus on the sleep apnea side of things, and I've brought Dr. Jeff Harrison into the studio with us to chat about sleep apnea. And so we're going to discuss my own sleep test. So here's my HIPAA disclosure that I'm okay with all of you knowing the results of my results, and how it can impact, ultimately, how can it impact your practice, your revenue, your bottom line, and most importantly, your patients and your patients' health. So with that, I want to introduce Dr. Jeff Harrison.
Hey, thanks, Darren. Happy to be here. It's been a long time. So you actually used to be a patient of mine, and then went on to my sleep career in another town. So we met yesterday, and I basically took you through an initial screening type of program. And so I asked you just some simple questions, which an assistant or a hygienist could be doing at any appointment where the patient's in the chair. And it's called a stop-bang assessment. So the stop-bang is an acronym, so the S stands for snoring. So have you ever been told that you occasionally snore?
Yes.
And T is for tired. So do you feel more tired than you used to feel? Do you feel like if you could take a nap right now that you would lay down and be able to take a nap?
If you're not exciting, I'll fall asleep, yes.
All right. And then has anyone ever observed that you stop breathing or breathe poorly during sleep?
Yes.
Okay, so you're at 3 of the positives right there out of the possible 8 in the stop bang. So right there, this is my first red flag that you might have a sleep problem and we should investigate the sleep further. The P in the stop portion of that equation would be blood pressure. So if someone was just taking a routine blood pressure, do you think they could, as a consultant, do you think any office could ask those 3 questions while they're waiting for a blood pressure cuff to pump up and then go down?
Absolutely.
So in 2017, the ADA has asked all dentists to screen all patients for this, and yet many of us aren't doing it. So if you were coaching a customer, do you see any obstacle or hurdle to why an office could say, no, we can't fit it into our schedule if they're taking routine blood pressures?
No, not at all. I mean, just any of those questions you're asking are easy things to add into all the other health history sorts of questions that they should be asking already.
Now, the back half of the stop bang, the bang portion of it, can pretty much be done in advance for patients that you've seen before, because B is for body mass index, so height and weight kind of comparison. You kind of know who your overweight patients are if you've seen them before. A is age, so hopefully on the intake, the person answering the phone has gotten their date of birth, so you know that age 50 and over has a higher tendency to have a sleep-related breathing disorder. N is neck size, so if you're thinking of the patient, you can't get the napkin chain to go around them, that's someone that has a large neck. Men, it's really easy because it's 17 inches or higher, and most men wear a collared shirt at some point in their life, so if they were to go shopping, they would know what to buy. For women, it's a little bit tougher, but again, that napkin chain trick is the one that I like. And then G is for gender, so if they're a male, they're 50, and they got a big neck, you're at 3 already, and you don't even have to ask them a single question. You're just going to advise that they get a sleep study done. So we did that yesterday, and then you went home and you were using the WatchPat device. And so WatchPat is a very simple instrument to use to study your sleep. It's worn on your non-dominant hand, a finger probe that goes on a finger that's really tight, and then a sensor that goes up your arm and sticks onto your chest, so we can monitor your snoring level and your body position. So what was your experience like last night taking the sleep test?
I found it to be really simple. It's obviously a pretty snug fit on your fingers. It would need to be to stay on, but it was simple. I mean, if you sleep with a watch, which I do a lot of times because I've actually been monitoring my sleep through an Apple app, which is what led me to the conclusion I probably had something anyway. It was a simple extension to just put a few more things on and do it. So I didn't find it to be any bit of a challenge at all.
Great. So I'm glad you found that comfortable. What we've discovered is in the research that this is a very accurate home sleep testing device, so much so that Harvard has graded it as 89 or 90% of an in-lab sleep study where you'd have stuff taped all over you. So you and I had this discussion yesterday, but last night, do you feel like that was a typical night's sleep even though you were taking a test?
Yeah, similar.
And then if you had to go to a hospital lab setting and sleep in a room that wasn't your own, in a bed that wasn't your own, by yourself, and have 18 different things taped to you, do you think I would get an accurate picture of your normal night's sleep?
I would assume not. I can fall asleep in a crowded room with lots going on because I have some sort of an issue, I think. And so, but I think I'm the exception to that rule. I could see where my wife as an illustration would be like, there's no way I could sleep where I know there's someone sitting on the other side of the glass watching me. Right. So yes, this is a far, far easier solution and testing methodology.
So when we talk to physicians, we still know that the polysomnogram, the in-lab, in-hospital sleep test, is the standard for diagnosing different sleep conditions besides sleep apnea, which is basically what we're looking for as dentists, is does this exist? So we know since 2008, medical insurance companies have been accepting of home sleep testing devices. And to use this as a screening tool in a dental practice, I think is, hurdle number 2. The first one is getting the team to ask the questions, stop bang. The second one is getting the sleep tested quickly. So if we were to refer this to a physician, which I did for a number of years, the patients come back at their next visit to the office and they've forgotten to go. And so having a sleep testing device in your practice is a great screening tool to moving the person along to the next step in the process. There's a couple states where the State Dental Board does not allow this. So Georgia's one of them and New Jersey's another. So we're fighting it as sleep dentist. The American Academy of Dental Sleep Medicine has petitioned these state dental boards to reconsider. Certainly we as dentists are not going to make the diagnosis. We're going to be a player on a healthcare team. But if the ADA is asking us to screen our patients, why do we have a barrier to getting the patient tested so they can get the care they need is our point. So you took the test last night and then you dropped it off back this morning at the office. We cleaned it up really quickly, downloaded the data, got a preliminary report, and at that point in the office, the person that received the test device back would schedule that patient for 2 weeks from now, and also collect the driver's license and front and back of their medical insurance card. Because while we may be able to offer a dental solution, this is really a medical problem. We're going to have a medical diagnosis so we can build a medical insurance. And once we get that diagnosis, then all the visits subsequently to that become medical encounters or medical visits. So that's where we go with that. So I've got your sleep report here. And at first I'm going to go over it in more detail than I typically would with an average patient, just because it's you and me, and we're going to probably be talking to other dentists right now. And again, this would be something that a well-trained sleep care coordinator would be doing and not necessarily the doctors. So I work for Sleep Group Solutions. We're a company that offers a turnkey solution to dental practices that are looking to add sleep to their practice, or someone that's gotten into it but has kind of hit some of the common hurdles. So how I talk to doctors about it is dental sleep medicine's like a puzzle. There's a few pieces to it. And if you've ever put a puzzle together, it's not a lot of fun to get done and be missing one of the pieces of the puzzle. And if it's the first time you're putting the puzzle together, wouldn't you rather have a friend that's done it thousands of times?
It's an easier way to do it.
For sure. So from your sleep study last night, we know that you went to bed at about 10:15 and you took the probe off your finger about 10 till 7 this morning. Is that accurate?
Yes.
Okay, so the device was recording for 8.5 hours and it was monitoring what was sleep and what was awake, because we're really just interested in what's happening while you're asleep. So it removed about a half an hour of data from the 8.5 hours that was recorded, because you took a few minutes to fall asleep and you might have had an awakening last night. Do you remember waking up at all?
Not other than to roll over once or twice.
Okay, and just a curious question is, do you remember having dreams last night?
Nope.
Okay. So we often see when someone has a sleep-related breathing disorder that they've lost the ability to dream, or they can't remember the last time they dreamed. And that's often one of the things that comes back once you get into a therapeutic position, or if you go into positive air pressure therapy. Sometimes they'll come in and say, wow, I'm dreaming like I was in middle school all over again. I can't remember the last time that I had a dream. So that might be something for you going forward as you get into therapy. If that comes back, maybe that'll be your, oh yeah, I didn't even think about that.
Interesting.
But so we talked about snoring, we talked about tiredness. If there was one thing that I could do, because I always like to identify that one thing, if I could help you in one way, what would you be looking for?
Energy.
So you want to get more energy.
Yep.
And if you had more energy, what's going to be the result of that? What would you do with more energy?
Greater productivity, not be dozing off, whether it be driving or sitting on the couch with the kids, just a greater ability to interact with the family in a different and more engaging way.
Okay, so that made me think of something else that I really hadn't thought of up to this point yet, is we also have a form called a bed partner questionnaire. Because typically a male is not going to present to the practice on their own. Maybe it was your wife saying, hey, you need to go see somebody about this, or hey, I'm really tired of you, falling asleep on the couch, as soon as dinner's over, just because you're so beat and worn out. So if the patient is not responding honestly about what the issues is, if you can get the spouse in the room,
For sure.
they will throw them under the bus left and right. So I've even got one doctor, and he says, when I added this to my practice, I didn't realize it was like making a movie for children. I'm like, what are you talking about? He goes, well, if you make a children's movie, they don't just drop the kid off at the movie theater. Mom and dad are sitting in there, and then the sisters and the brothers. He goes, as soon as you start having a successful outcome with what you're doing, all of a sudden you've got mom, dad, brother, sister, cousins, co-workers. It's amazing. So we got about 8 hours of sleep data time, which is fantastic. And we found that, we have all these different numbers and they get a little scientific, and I don't like to talk to patients about this. So I use common words. So for one number that doctors will use, it's a score called an AHI. It's how many times did you stop breathing for 10 seconds or longer. That's called an apnea. Or how many times was your airflow reduced by 35% and a 4% drop in blood oxygen level. That's called a hypopnea. So we add up all of those overnight and then divide by the amount of time you were asleep, and we come up with an index or an average per hour. So I like to give the total number first. And I use the words choking and suffocating, not apneas and hypopneas, because most people don't know what that is, even dentists. So last night you had 172 instances where you were choking or suffocating during your sleep. So do you think that might play a role in why you're feeling tired?
How many would a healthy person have?
They would have 5 or less.
That's a big number then.
Ideally, I'd have none. And if we could cut that in half, that would be considered success in the medical world. So if I could get your score, which is right now 21 to 22-ish, because I like to drop the decimal point, if we could get that down to 10, that would be considered success, even though 5 and less is considered normal. But imagine how much more energy you would have if you only had half of those occurrences.
Profound, I would assume.
The number that's next to that is called an RDI, or Respiratory Disturbance Index. So it's the same thing as before, where it's how many times you choked and suffocated, but there's other things that don't qualify for either of those definitions, but it's not normal, healthy sleep. So we have to add those in, and that gives us a bigger number. And when I was talking to you yesterday, because I've seen thousands of patients that were like you, that wouldn't be your stereotypical old fat guy that you think, oh, they've got sleep apnea. I said, I bet you're going to have more fragmented sleep than more instances where you're choking or suffocating. And I was on, but you did kind of surprise me in the number of times that it's actually an event where you stop breathing for 10 seconds or longer, or an event where you breathe so slowly or poorly that your blood oxygen drops. And it's not a one-time occurrence. Like if I had a pulse oximeter on your finger, we'd have a static kind of baseline oxygen. And in fact, we measured that last night, and on average, you were at 92%. So 90 and above is considered normal. But if you were to hold your breath, you would probably never see that percentage drop by more than 1, if you could even get it to move at all. But when this happens cyclically or repeatedly, that's when we start to see the impact on our body and the drop in our energy level. So you were in bed for 8 hours, but you probably when you woke up, because I called you this morning, like you still sounded a little groggy, and you're like, man, I got to get my coffee in me because I need to go tend to the horses and plow the driveway and all that stuff. So your day starts early, and it starts with lots of hard work, and then it leads to the office. So we did have some desaturations. We had 59, in fact, over the course of your 8 hours of sleep. So if I was to do the math, and you're the math guy, like how many on average would that be? So if you had 8 hours of sleep, so it's about 4 times an hour, yep, roughly. More than that, really. It's like 7. 7 times 8 is 56. Yep. So less than every 10 minutes. So I think if you were someone that could be assisted with oral appliance therapy, that you're going to see a huge jump in your energy. So that's the part we got to figure out next. So we know that your sleep quality, as far as the percentage of what you were doing during sleep, was kind of on average. You had about half the night was light sleep, which is typical. A little bit over the quarter of the night was rapid eye movement or your dreaming sleep, even though you don't recall dreaming. And then just a little bit less than a quarter was your deep sleep, which was reparative sleep. And you have that first in the night typically. We see deep sleep first, and you told me something that was very indicative of that, as far as like when you fall asleep, you just
crash. Just crash and crash hard.
And do you find that when you lay down to go to sleep, do you typically fall asleep in just a few minutes?
Oh yeah.
Because that's the classic sign of someone that has excessive
Instantly.
tiredness.
Yep. Instantly.
And then would you say most mornings you wake up feeling refreshed and want to get out of bed, or you
No.
would rather linger there for a little bit longer?
Yep.
Okay, so as your healthcare provider, that's kind of what I'm looking for. Subjectively, you're going to be telling me that, yeah, it takes me a little bit more longer to fall asleep now, and when I wake up, man, I feel like I'm ready to go and I can last longer through the day. So obviously, I'm glad you got your sleep studied. At this point, we would have sent this off for an interpretation by a physician to have it come back to us. So we kind of jumped the gun there a little bit with me looking at the data. But as a dentist, I can't make this diagnosis. It's up to a board-certified sleep physician. So that's why we had that appointment 2 weeks later after the patient drops the sleep study off. It also gives the front desk time to submit the insurance information. So that is a common hurdle as well. Most dentists that get into this, they don't want to deal with medical billing. Or if they've tried medical billing, they found out it's a whole different beast than dental. And so part of Sleep Group Solutions packages, we pair them with a qualified third-party biller that's used to dealing with practices that have high volume in dental sleep medicine. So they're going to research that, find out what the deductible is for the patient, because the patient's going to want to know a few things when they come back. Am I a candidate? Can you help me? If so, how much is it going to cost, and what's the insurance going to pay? So we're going to move into that next step then to see if you're someone that would be a candidate for oral appliance therapy. And this part we haven't done yet, so this will be new for you. So
Sweet.
I get to don some gloves here. We may want to flip to the other screen so they can see what's going on, but we're going to put in, what's the date today?
24.
Got it. We'll use today's date as our identifier, and we'll put in just your initials as your patient ID. And then instead of typing your name, I guess I can type it, Darren. And we'll just put last initial. I'm going to skip over to height and weight because I wanted to calculate the BMI. So what is your height?
6 foot.
No inches, just 6.
Yep.
And weight?
195.
All right, so your BMI is 26. So 26 and greater kind of gets into that zone where we start to see a higher incidence of sleep apnea. You are a male, and we would go to next. It's going to tell me to save it. Quick medical conditions. Have you been diagnosed or take blood pressure medication?
Negative.
Do you have heart disease?
Nope.
Do you have diabetes?
Nope.
Lung disease?
Nope.
Do you have insomnia?
I wouldn't think so.
Okay. Narcolepsy?
Yeah, perhaps.
Really?
No, not really.
You're kidding me. Okay. Do you take sleeping medications?
No.
Have you had a stroke?
No.
Are you depressed?
Some days.
Yes. In the last year, I think we've all been depressed.
Yep.
Have you been diagnosed with sleep apnea?
Not prior to today.
Well, you're still not diagnosed because I'm just a dentist. But if I was to send that report off to a physician, I think your diagnosis would come back moderate. So, and I don't even like mild, moderate, and severe. I use stage 1, 2, and 3 because people are used to cancer.
Sure.
And so, if something's mild, you might ignore it. But if stage 1 cancer is present, you want to get it before it's stage 2. So, same thing goes for me in sleep disordered breathing. I'm guessing you probably don't use oxygen.
Nope.
We talked a little bit about restless leg, which a lot of people are unaware of how it's associated with sleep. Do you have that?
Not to my knowledge.
Okay. And are you waking up with headaches in the morning?
Negative.
I thought we talked about that yesterday. Okay.
Yeah, on occasion, but more of a bruxism thing and pretty infrequent, I would say.
Okay, but maybe headaches, bruxism.
Maybe.
And are you taking any pain medications?
No.
Okay, so medical history is pretty clean. The next one's called an Epworth Sleepiness Scale, and this is a very subjective questionnaire. It's 8 questions. You can answer 0 for never, 1, 2, or 3 for more often. 3 obviously is the top score. And the only reason we do this is because medical insurance is often involved. And they're looking for a tiredness level in order to qualify you for care. How I like to do this is I want you to close your eyes, and I want you to think of the day of the week where you're most tired. Okay, what day is that?
Thursday, Friday.
So we're going to take you to Thursday or Friday. And what time of day is it?
6:30 p.m.
So I want you to answer these questions as if it was 6:30 p.m. on a Thursday or Friday. With 0 never being a chance to doze off, 1 a slight chance of dozing, 2 a moderate chance, and 3 high, how would you be at 6:30 on a Friday or Thursday evening if you were to sit down and read?
Asleep.
So a 3.
Yep.
What if you were watching television at that same time?
Man, if it's a good movie, I wouldn't fall asleep. If it's a boring movie, I'd fall asleep.
So
2.
2. And if you were sitting inactive, like maybe the movie theaters opened up and you got to go to a movie finally again, or you had a meeting that was happening at Thursday afternoon, Friday afternoon.
2 at least, maybe 3.
And if you were to get into the car and maybe drive up to the cabin in the mountains, but you were the passenger, and it's Thursday afternoon after a long, hard week,
2, 3.
which would you choose, 2 or 3?
I'll say 2.
Okay. And then if you got home and kids were gone, wife was gone, and you could lie down and close your eyes for a few minutes, would you doze off?
Yep. 3.
Great. And if you were sitting talking next to someone, maybe a friend was, maybe I came over, we were just sitting around, hadn't seen each other for a long time.
Man, that sounds rude if I say 3. 2.
No way. I don't believe you. But if that's what you say, I'll put 2. Okay. And if you were sitting quietly?
2 at least.
Okay. And then you're driving home after that long, hard day on Thursday afternoon, and you get stuck in traffic. There's an accident. The road's closed for a few minutes.
Oh, 3.
Okay. So congratulations. You scored a, 19 out of a possible 24. So the score that medical insurance is looking for to classify you as tired is 11 and higher. And dentists that get into this, sometimes they'll just hand them the form. And so if you've ever handed a patient a form for medical history, you've seen what they do. They don't answer it relative to what reality is.
Sure.
And you can't really ethically say, hey, you got to score an 11 or higher, in order for your insurance to pay for this. So the method I prefer to do is let's frame it into that mindset of tiredness. Because if you just say, if you were to sit down right now, would you fall asleep? Well, probably not, because we're shooting a video, we're awake. So you got to put them in a mindset that's a little more realistic for it to score higher. Research has shown that if you just hand them a form, you're going to get an average score of 6. So now if we have coexisting medical condition, that becomes another situation. But I hope our attendees can see the screen where they see these little dots turning from red to gray to green. So this entire software program has been built to run a sleep practice inside of a dental office for someone that knows zero about it. We come in, we train your assistant or your hygienist or a sleep care coordinator to do this, and the software prompts them through. So you don't have to take a whole lot of classes in order to get started. And the program helps you sort of become an expert really quickly. Cool. So, with sleep behaviors, these are just some more things we're looking for. On average in the past month, how many times have you been told that you snore? 1 time a week, 2 times a week, 3 or 4, or 5 or 7?
Like constantly.
Every day.
Yep.
And do you ever wake up choking or gasping?
Not to my knowledge, but I'm told yes by my wife.
Okay, so we'll give it maybe a 1 then. And then in the past month, have you ever been told that you've stopped breathing or that you were choking or gasping while asleep?
Yes.
And how many nights in the last month?
Ooh, I don't know. Couple, let's say. I'm not sure.
Okay, so maybe once or twice a week, or?
Yeah, no more than that, I don't think.
Okay. And then do you have a problem keeping your legs still at night?
I don't think so.
But we did talk about how you flip and flop around.
I do flip and flop.
Good.
My arms fall asleep.
Great. So the next part we go into a clinical exam, which is pretty typical for a dental appointment. I would actually take the patient's cell phone and say, do you have a cell phone? And then I would take a picture of their airway so they can see what I see. So I'm going to do that with my phone real quick for you and just turn it around for you. I just want you to open for me. And let's see, make sure my flash is on. And then I want you to just stick your tongue straight forward. All right. So what we're looking for there is, can we see the airway? And when dentists are doing an exam, we're so trained to look at teeth and then pick up the perio probe, whatever we do first. A lot of times we skip past looking in the throat. Sometimes we're doing it when we do an oral cancer exam. So I always like to start from the back forward because it's something new. And I always say, open up your mouth, I want to check your tush. I'm looking for tongue, uvula, soft palate, and hard palate. But it makes people laugh.
It does.
So I can see some redness in your throat, but I can see the uvula, which is the little thing in the cartoons.
Yep.
I do see a kind of a V-shaped tongue, so to me that might be an indicator that you might be tongue-tied. I see redness coming in from the sides. Did you ever have tonsils taken out?
Nope.
Okay, so that's probably what's coming in from the sides there without getting...
I've had a history of tonsil stones.
Okay. Interesting. And then why we do the tongue forward is just, does it elevate or get smaller? So you get a little bit smaller there. What we're also thinking about here is pretty much my last 3 years after I left here being a general dentist and became kind of just a sleep dentist, all of my patients were coming in with severe problems. So I could hardly ever see airways in their throat. But again, the answers that you gave to the stop bang, the chief complaint of tiredness, and then the results of your sleep study last night, you're probably the patient that's pretty typical that walks in and out of a dental office. And I know when I was your dentist, I never talked to you about this. Mm-hmm. And I would say most dentists probably aren't thinking about it either. So as a coach, for a business coach, what role do you see by adding dental sleep medicine to a practice? Is it just untapping potential revenue that's already there?
That's the obvious low-hanging fruit, but I think even more important than that is every dentist I've ever met, or almost every dentist I've ever met, really, really, truly cares about their patients and has a fondness for their health. That's why you guys went to dental school. And yet we're skipping this important piece, because as you said yesterday when we sat down to chat, is in the medical world, I'm going to be brushed away because I don't look overweight, I don't look at risk, I don't have all the typical red flags, but yet I'm the person who's falling asleep driving a car and ending up in a ditch or dead. Mm. And so to me, the value of this outside of the revenue thing is you literally could be saving somebody's life. Because if I make the assumption we come back and film in 4 to 6 months or some time frame, I'm going to have a completely different energy, and I'll be safer in a car and probably more engaging in the evening. So to me, the biggest value here is the relationship you're going to build with the patients, because you care about something that's sort of outside of your realm, but kind of in it at the same time. And I think, the Maya Angelou quote of no one knows how much you care until they know how much you care. I think I butchered that. But whatever the case is.
They don't care how much you know until they know how much you care.
That was it. I'm famous for doing these things. Anyway, whatever the case is, it's interesting to see, because I think by going this extra step, this extra mile, you bring so much more care to the patient. Patient care, right? That's the whole thing that you went into medicine for. And I think it just elevates it to a completely different level.
Yeah, we have a whole segment in the 2-day course where we go through about an hour of historic accidents where trains have crashed into terminal stations, buses have run off the highway. And then we have one of the cartoons in there to just kind of break up the sadness of the whole topic with, I want to die peacefully in my sleep like my grandfather did. Not like the passengers in the car. So, when we're drunk driving, we're dangerous, but at least we're awake. And so if we hit the side, we'll react. There's countless videos on YouTube if you just search for, truck accidents where the truck driver fell asleep and just plows in, takes out 9 cars before everything comes to a rest. So this is more fatal than drunk driving. This is also more fatal than texting while driving. And so we've got laws against drinking and driving. We've got laws against texting and driving, but there's no laws preventing people from driving when they're tired. And so when I give a lecture, I'll usually ask, stand up if you've ever been tired while driving. And pretty much everyone in the room will stand up if they're not already asleep, and then they just stay seated down. So. All right, so we're getting into kind of the technology part of the screening process. And had you not already taken a sleep study, if you were a typical male patient that wasn't presenting with a chief complaint and you're just trying to get out of the office, these first 2 tests would be the things that I would do to convince you that you need your sleep evaluated. So I have not done this yet on you, so I don't know what the results are going to be, but we'll go off the cuff here and we'll see if it correlates with what your sleep study showed. So, having done it a few thousand times, I think I know where it's going to end up.
Probably.
This is just sound technology. It's called echo vision. We're going to use a rhinometer, so we're measuring if you could breathe through your nose, and then a pharyngometer to see if you can breathe through your mouth. So when I moved away from Colorado Springs, went up to Steamboat, there was 2 rivers that came together. So it was a great analogy. When the river's wide and the water's moving, it really looks very calm. But when the 2 rivers come together and it gets narrow, the rapids form, and so there's turbulence, and that's what snoring kind of is like. It's trying to get a lot of air to go through a tiny space, and so we make noise. So we're going to be using sound to measure that, and we have to calibrate our instrument every time so we get an accurate measurement. And we're just going to hear a knocking sound. So that's the noise you're going to hear. During COVID days, we have to explain to people that we're not sticking this in your nose. It's just a calibration tube. And then we have different size nose tips. So there is an angle to this. It's going to go high side towards the ear. The graphs are labeled left and right before decongestion, because if we had stuffiness or seasonal allergies, we could measure before we give some sort of decongestant like peppermint oil or an Afrin or a clear with Afrin in it. So we're just going to put the tube on. And we have a small and a large, or a normal and a petite is what I like to call them. So just good posture and normal breathing until this touches your nose, and then I want you to pause your breathing for about 7 seconds, and you'll hear the
Breathing in my nose or in my mouth?
breathing through your nose.
Okay.
And then pause your breathing when I touch your nose.
Okay.
Okay. So just looking straight ahead. There we go. And we'll turn it to the other side, same test. There we go. All right. Are you aware if you breathe through your nose? Do you breathe?
I feel as though I struggle, like I literally have had this thought where I feel like I struggle to get enough air through my nose. So I know at night I'm primarily a mouth breather.
Okay. So we know it's important to breathe through our nose for the production of nitric oxide, which is your body's natural way to reduce inflammation. And we only do that when we breathe through our nose. But we don't want to tell somebody to tape their mouth shut or make a device that holds their mouth shut if there's some kind of obstruction in the nose. So good news, Darren, is the measurements of your nose on both left and right side are within normal limits. So the purple line in the graph is your left side, the orange line is your right side, and all three of those are passing through the three anatomic landmarkers that we have in here. The first blue line was the start of your nostril. So on the x-axis, we've got measurement of distance. So 0 centimeters, 3 centimeters, and 6 are labeled. The y-axis is square centimeters in size. So nostril, the first triangular shape we see is the nasal valve. And if we saw a lower end of normal, or we saw a collapse when we were to look in your nose, so if I was to have you look at me, tip your head back and do this. So sometimes, like my nose,
Your right side
collapses. Your side's more stiff. So there's products on the market that can buy at a Walgreens or a CVS that helps hold that open. So it sort of looks like a swimmer's plug, only it does the opposite. Instead of pinching things closed, it supports them in size. But your nasal valve is above average because the big line in the middle is statistical average. Then you're a little bit small at the anterior portion of your inferior turbinate, and it stays small towards the backside. If these lines tanked off or were really below normal, that might institute a referral to an ENT to take a look at the nose to see if maybe they could help you. But the good news is your nose is within normal limits, so if you wanted to try to train yourself to breathe through your nose, making a device that helped your mouth stay shut while asleep, or a piece of tape over the lips to help train yourself to breathe through your nose could work.
My wife would love that all day.
Yeah, I bet. She's the one that paid me to say that. All right, so that is the nasal airway. Now we're going to move on to, since we know you're a mouth breather, what impact is that having on you? And have you ever gone snorkeling or scuba diving?
Yes.
Okay, so you're familiar with what a snorkel does.
Yep.
This is a tongue depressor, so your tongue's going to go underneath that. Lips are going to go on the outside of it, so it's sealed. Teeth are going to come together left and right. Okay. We're going to have you pinch your nose while we have this in there. You're going to breathe in and out through that big hole there. Okay. So go ahead and put that in. Bite together. Normal breathing. And what I'm capturing here is just a baseline. So I'm going to watch the rise and fall of your inhale and exhale. And that's average. Now I'm going to have you stay right there. I'm just going to go to the next graph. Now we're going to do a collapse test. So same breathing. And now when you're ready, I want you to get a good breath in. And then I want you to really slowly breathe that off. all the way out. And before you take your next breath in, raise your other hand to let me know you're out of air. So, is that raising it, or is it? Okay, there we go.
Sorry.
So the other thing I always like to talk to dentists that are getting into this is that patient that always falls asleep in your dental chair. You know, I used to think you thought I was one heck of a dentist, but now I know you were just tired.
I did fall asleep in your dental chair.
This is true. So we're going to compare our baseline graph to our collapse. And if our minimum changes, if we have a decrease of 25%, that's usually indicative of someone that has a highly collapsible airway and may have obstructive sleep apnea. So in your case, your minimum goes to almost 51% decrease. It cuts it in half, 1.5 to 0.85. So we saw the same results in your sleep study, where it happened, I don't know, I told you some huge number of times, 172 times over 8 hours, which gave you an AHI index of 21.6. So almost every 3 minutes you were having disturbed sleep. The next question becomes, and this is where most dentists don't have the technology to know the first answer to the patient's question. Am I a candidate? Can you help me? Will this work? And so I'm going to use what's first called a snore key. So can you make a snoring sound for me? All right, so we're just going to test different vertical openings between your front teeth to see at what level does the sound disappear.
Okay.
Or if it disappears, it may not. Okay, so we're going to have you open, bite together. Can you snore? Okay, open, stair step you forward, and open. Okay. All right. So didn't really tell me a whole lot. So now I need to go with some more fine-tuned measurements to see what's actually happening when let's see a normal bite. So you have kind of normal tooth relationship. We're going to put you edge to edge, which brings you forward a little bit. Then we're just going to text 6, 8, 10, maybe 12. And if you do them in order the same time, every time, then you don't have to label your graph, so that's perfect. The other thing is we're going to lose our tongue depressor so we can get around the jig. And you might have to help me get this in there. There you go. Go ahead and pinch your nose just like before. Normal breathing just like before. And then when you're ready, a good breath in. And then blow it off and stop me at the same point as you did before. So when you're out of air and you're just about to take that next breath in. Okay, there we go. Take that piece out. Was the test easy?
Yep. Piece of cake.
Okay. Now we're going to go a little bit larger. Open just here. There you go. And I don't even stop to look at the numbers. So same posture as before, same breathing as before. Normally there's a tonal here, but because we're recording, I don't. So now when you're ready, a good breath in, just like before, and then breathe that off, just like before, and stop me when you're out of air. Okay. I can even kind of hear a sound change. Yeah, did you kind of hear it? So that was 8 edge. Now we're going to go to 10. There you go. You're getting good at this. Okay. Normal breathing. We're going to wait about 5 seconds. Normally we hear the machine go bing. Now when you're ready, a good breath in. And blow it off just like before. Okay. So now that we've got those 3, let's see if there's one that stands out that's better than any of the others. So I just want to compare. First one to the second one, so that's 6 versus 8. And 8 goes up a little bit, but overall it was a little bit worse. And then let's compare the first one to the third one. First one's still the winner. And we're going to add a couple graphs and slide over. So the less we have to change, the more likely the patient's going to be compliant with whatever you put in their mouth because it's going to feel natural to them. So I want to go as little as I need to in the vertical and as little as I need to in the protrusive movement. Most dentists that are taught dental sleep medicine, it's just one set vertical, and they just start jacking the jaws way forward, a percentage that's been shown to work 50% of the time. And to me, I never liked that approach. I'd rather see that it's going to work, have the confidence to tell the patient, if you wear this device, it will work, because now they're going to be more likely to be compliant with my device. If we haven't shown them anything and we just say, yeah, this should make you feel better, and they don't feel better, then they're just going to stop wearing it and they're going to ask for their money back, which is what you don't want to have happen. So you're that person that probably would be successfully treated in any dental practice that's doing dental sleep medicine because you don't need a whole lot of vertical. You know, your snoring sound was always there no matter where it went to. So the next question is, can we improve you enough to where it might help you? And if we can't, then we're just going to stop there and say, you're just not a candidate. I'm sorry. You know, you need to go see the physician and you need to get on positive air pressure therapy and see how you feel after that. Other alternatives would be surgeries, but most people don't opt for that. They're going to try the least invasive thing first. So now we're going to go back to 6 millimeters of vertical, and instead of being edge to edge, we're going to go 2 millimeters forward from edge to edge. And bite down, you're going to have to really come forward. How's that feel on your jaw joint there?
Fine.
It's okay. I'm going to kick that over to the straight on. There we go. Okay, normal breathing, just like before. Now when you're ready, a good breath in. And then we're going to blow that breath off, just like before, and stop me when you're out of air. There it goes. Okay. Good.
Does the fact that I wore a occlusal guard last night play any role in this?
That's
Because I wear one every night.
That's a good piece of information. So your sleep study is a baseline with an occlusal guard.
Yes.
Now, ideally, I'd probably want to see a baseline with nothing in the mouth, because then I would know really if you're different.
Sure.
There's also instances where the night card could potentially be fatal because you're eliminating all the interferences. So if you have a tendency to have these events, it's like putting a sheet of glass or a sheet of ice between your teeth.
Which I chewed through my night guard.
Yes. So not always, but sometimes sleep bruxism is related to these attenuations. So it's how, like I said yesterday, you know, if you're clenching and grinding during sleep, there's stress from somewhere, whether it's the events of the day, whether it's physiologic stress. I think a lot of us don't think about that. But if you were walking through the woods and, you know, a bear jumped in front of you, your sympathetic nervous system kicks in, and so it goes to fight or flight mode. That's sort of what's happening as well when we aren't breathing well in sleep. The brain says, you know, wake up, take a breath, and all of a sudden nervous system's invoked. Oftentimes this is someone who doesn't have any trouble going to sleep but wakes up 4 hours later and just cannot go back to sleep. And they'll self-diagnose themselves as insomniacs, but oftentimes it's a breathing issue that's going on. So that was 6 and 2. Now we're going to go to 6 and 3 to see if it gets better or worse, because you can actually overshoot the mark, which is what a lot of doctors don't understand. How's your jaw feel there? You feel like you're getting way out there?
That's right.
But you're also used to wearing something, so that helps. So normal breathing. And now when you're ready, a good breath in. And then blow it all the way off. And then raise your hand at the same point when you're out of air. Okay. I'm going to redo that because, go ahead and bite down. There you go. Your jaw went backwards. So the pitch on the device was angled down. So you're struggling to be way out there because these are probably tight. So keep coming forward. There you go. And see how that changes. Normal breathing. Good thing about the test, you just repeat it. And now when you're ready, a good breath in. And then blow it off. Raise your hand when you're out of air. All right. So the good news is the line looked pretty much just like it did before, so we repeated it, which gives me confidence. Now we're going to compare. We can actually go back and label them too before we get too lost here. So I'm going to put in, can you type these for me since you're closer? V6 and HE/E. And I'll save that. And then the next one is going to be delete. This was V8, H edge to edge. And then this one was, erase that, vertical of 10, horizontal edge to edge, HE/E. That's what I'm abbreviating.
So E/.
H, so horizontal, edge to edge, E/E. Sorry, wasn't
Not sure
descriptive in the beginning.
I don't know if I missed that on the other one.
No, I think you did it right. And then this one was where we went back to vertical was 6, horizontal was 2. So V of 6.
V6.
V, delete those 3. V6, H2. And then the last one. Delete that. This one was vertical 6, H3. All right, so now we've labeled our graphs so we can keep track of them a little bit easier. I want to compare the different ones that were the same vertical. So 6 edge to edge versus 6 and 2. So we actually got smaller when we brought you forward. And I bet that trend will continue if we went vertical 6 edge to edge and 3 and 3%. Not really enough to make me want to jack your jaw that far forward. So 6 millimeters vertical edge to edge seems like it would probably be our best position today. Let's compare that to your initial collapse to see how much improvement we might be able to get with oral appliance. So 41% improvement, or it brought your minimum back up to 1.2. So if I were to hold your head underwater and you breathed all your air out, and I gave you the choice of 3 snorkels, you know, one's a shake straw, one's a regular straw, one's a coffee stirrer straw, which would you think you would breathe best with?
Probably the big one.
The big one. I can't get you here, but I can take you from this with your night guard to this with an oral appliance.
It'd be interesting to, as you indicated, to have that sleep study without the night guard, because I wonder if it would improve it or make it worse.
I don't know.
Yeah, because that's interesting to see. Because as I'm sitting here looking at this, I mean, I can see that the opening of it doesn't really help it. Helps it a little bit, and the more protrusive I am, the worse I am.
And we know with the existing appliance that you have now, the apneas are there.
Sure.
So you've got a problem with this device, so you have the wrong device right now. But oral appliance therapy is always a good investment for the patient, because even if they're not going to wear it for sleep apnea, they would still have a night guard if they need to protect their teeth from parafunction.
Sure. Makes sense.
We can also use oral appliance therapy in combination with CPAP therapy. So the patient says, you know, I don't want to wear the mask. Let's try this first. Depending on the severity of the disease, I might advise against it or I might accept it. But if there are severe cases, sometimes we can do a combination therapy where they'll wear their oral appliance and they'll wear their CPAP. And then here in Colorado, where we're outdoorsy people, we like to go hunting, camping, backpacking. What are the odds that we're going to tote along the extra bag, or for multi-nights in the woods hunting, that we'll have the capacity to generate, you know, a battery sufficient to run the machine. So
No way.
alternative therapies are great. Sometimes they're in combination. Sometimes it's one or the other. But patients, when they own their problem, you know, doing nothing's not a great choice.
Sure.
So thanks for your time. That was a great demonstration. So hopefully that was helpful.
For sure. I learned a lot. It confirmed what I already thought was an issue, but allowed me to put science behind it.
Mm-hmm. So I'm from Missouri, and you have to show me that
Exactly.
there's a problem. You got to show me that's going to benefit for me. So great.
Thank you.
You're welcome.